So we're going to start out by talking about kind of the broad picture of behavioral health issues, and then we'll get down specifically to minorities and then African Americans. We'll talk about some of the resources as well as some of the mechanisms that are perpetuating issues within the communities that we see. So we've talked over the last 2 days, day and a half, about the burden of the issue, and we get that it's extensive. We get that a lot of people are suffering from mental illness and substance abuse, but the projection is that by 2020, behavioral health, mental health issues are going to be the leading cause of disability worldwide. So not just in the United States, not just in Region 6, but worldwide. So the burden is extensive. We know that when we talk about mental illness, we know that most individuals are diagnosed around the age of 14, with most diagnoses happening between 14 and 25, and then with most adults having at least one mental illness in the course of their lifetime. So we are going to be impacted by this issue. When we look at subpopulations, we look at the prison system. We have about 80% of state prisoners, 72% of federal prisoners, and 82% of jail inmates that have a mental illness or substance abuse problem. We look at the money that we're spending in this area, and we have about $510 billion spent. So again, an extensive burden, extensive issue that we're dealing with. And then when we talk about health implications, suicide is in the top 10 leading causes of death, so ranked number 10. And the projections are that in 2015, it'll be the 8th leading cause of death in the nation. And when we look at African American suicide rates, and it was touched on in earlier presentations, we've seen a growth of 233% amongst African American men aged 10 to 14 in the last 5 years. 233% growth. And so, as was mentioned before, sometimes these numbers are just that, numbers, right? So you don't really get a full picture of what's going on. But when you look at the prevalence, the numbers of folks that are impacted by mental illness, the numbers don't really vary across racial and ethnic groups, except for biracial and multiracial individuals. But where we see the greatest difference is in how we deal with these numbers. What do you do to cope with life? How do you handle when you have a bad day? And it's where we see those differences really play out. And that's what we'll be talking about. So overall, minorities have lower rates of lifetime mental illness, and specifically, blacks have the lowest rates of lifetime mental disorders, but we're more likely, once diagnosed, to have illness that's persistent and severe. So if you have a diagnosis, it's usually grave. And then again, the disparities that we see, the manifestation happens, and that's where our real concern becomes. So you have Native Americans, you have an increased dependence on alcohol. African Americans, you have an increased dependence on illicit drug use. In Region 6, the drugs of choice are cocaine and marijuana. And the statistics show that about 86% of those suffering with mental illness in Region 6, 86% use marijuana or cocaine as a coping mechanism. The National Alliance on Mental Illness, they do a scorecard of how the nation is dealing with mental illness across the nation. And when you look at Region 6, we have some differences in how our states cope and deal. But when you take, I'm an educator, so we like grades, right? When you take an average of our region, Region 6, our average grade is a D- for how we deal with mental illness, a D-. So I have kids, and so I say a C is average. Anything below a C is below average, and we don't even like to get to the C point in our house, right? So we have a lot of work that can be done and needs to be done. Overall, the differences that we see in health disparities related to mental health, we see that minorities are less likely to receive treatment. We see that outpatient happens differently for different groups, that blacks and Hispanics are more likely to receive state help than through private care. We see that more blacks are likely to be hospitalized and that racial differences are confounded by those social determinants of health. And we'll talk about these specifically. And to kind of just give the overview, the biggest disparities or the greatest disparities that we see are access to quality services, help seeking and help utilization, negative experiences with the system, stigma, cultural competency issues, and the lack of inclusion in research. So then what are we talking about? When we talk about behavioral health and mental health, we're talking about those coping strategies, the ability to function in society. And again, this is where we see our greatest differences. So I teach at Langston University. It's a historically black college, about 45 minutes northeast of Oklahoma City. And so I ask my students, well, when we talk about mental health, when we talk about behavioral health, what comes to mind? And these are the folks that come to their mind. And they were like, well, you remember when Mike Tyson bit off his ear? That was crazy. That's what we're talking about. And, right. Right. So they think about the extremes, right? They think about what's happening in the extremes. And so as we began to kind of debunk and really peel back the layers of what we're talking about, we're not just talking about the extremes, because we certainly see this, but we're also talking about the fact that 7.5 million African Americans have a diagnosis of mental illness, and about the same number don't have the diagnosis and are untreated. We're not just talking about these extremities, but we're talking about us. We're talking about single moms. We're talking about multi-generational families. We're talking about kids. We're talking about us, the lives that we live daily, not just the biting the ear, not just the depression, but things that affect us. And so I wanted us to take a look kind of at the history of mental health, because I think it frames for African Americans what we see currently. So at the start of time, we had a lot of self-treatment across all cultures. We took care of our own. We did things for ourselves. We had lots of family support. But then over time, we had slavery in the United States. And for slavery, the interesting thing for African Americans was that this was the same time that the field of psychology was emerging. And so you had a lot of diagnoses of things that weren't really conditions. So the two common diagnoses for African Americans were negritude and drapetomia. These two conditions were characterized by slaves who wanted to be free. When you ran away from your master, you were considered mentally ill, and you had drapetomia or negritude. And so what they were looking for were skin lesions. And so you get skin lesions by being beat and whipped, and then you want to leave, right? You want to flee. But that was the same prescription for treatment. So they said, well, if you have a mental illness, you have drapetomia, you have negritude, to get rid of that, you need more beatings. And so this idea continued to be perpetuated. We see over the course of our history, we have institutionalization, where these slaves were then transported into institutions, which didn't have any better treatment, but had the introduction of things like eugenics, forced sterilization, guinea pigs, okay, we'll go with that, forced sterilization. So the idea, again, because psychology is emerging, we have this idea that if blacks are lesser than, we'll treat them anyway, and we'll treat their symptoms anyway. We don't want them to reproduce, so we'll stop that from happening. And then we have a movement of deinstitutionalization. In the 50s, 1954, psychotropic drugs became available, so we said we'll give them drugs and send them back into the community. No idea about follow-up, no idea about systems of care, no idea about how to navigate systems. The issue becomes then more prominent and prevalent because my family now has a history that we're going to share, and we don't want anything to do with this system. Whether it's good or bad, it gets better, we don't want anything to do with that. And over the course of the U.S. history, once deinstitutionalization happened, unless you were really in the behavioral health field, we have a long history since then of just kind of ignoring the issue. We're not going to deal with it, which then leads us to some of the tragedies that we're seeing. In the 80s, we had going postal with the postal worker in Edmond, Oklahoma. And not saying that behavioral health issues manifest themselves always in tragedy, but we see this kind of proliferation of these events because we're not figuring out how to cope effectively with life. So then, what's causing all of this to happen? And certainly you have to look to history because that shapes future behaviors. But two of the greatest movers, if you will, about the disparities in care are system level and patient level factors. And we'll talk specifically about those. So we have within the system level factors, excuse me, we have provider bias and stereotyping. We have statistical discrimination. You have issues of access to care, provider and geographic differences, and then health insurance differences as well. So we know that evidence suggests that stereotyping, biases, and uncertainty on the part of healthcare providers contribute to unequal treatment. And so we know we like to categorize people, right? We know that because that's how we make sense of the world. We have automatic stereotyping, which is the things that happen subconsciously. So I see an older person walk in, and because I think I know what older people are like, I just start ascribing kind of characteristics to older people based on what I know. And those are automatic stereotyping. But what we're really concerned about is when you take that automatic stereotype and goal modify it for practice purposes. So you take that stereotype that you have subconsciously, and then you say, well, all people are like that, so we won't prescribe treatment. All people are like that, so we'll prescribe this kind of medication, or we won't allow them to do this kind of treatment. And that's where we see problems and issues within our healthcare community. So this goal-modified stereotyping, what we see is that when it's in practice, clinicians order fewer tests. When they don't understand, they order more tests. And Harvard University has come up with a tool. It's called Project Implicit, and I would highly recommend you check it out if you haven't done so. But it has a series of assessments. It's online. It takes about 10 minutes, where you can see what some of your underlying stereotypes are. And then they compare you to other people who've taken the test. And so they have this kind of these assessments for different groups of people. So you can do white and black, you can do homosexuality, you can do Asians or Muslims, all of these different kinds of groupings of people to see where your underlying assumptions are. They give you a report at the end, and so you see in the report kind of where your biases are and then how your biases compare with other people. So some of the patient level factors regarding mental health issues deal with urban settings, poor social support, stigmas, barriers to care, socioeconomic status, and substance abuse. And so we'll talk about a couple of these specifically. The adverse childhood experience, and this has kind of been touched on in several different presentations. It's a joint study by CDC and Kaiser Permanente, and what they found is that the experiences that we have in childhood really do shape what happens later in life. And so the more adverse childhood experiences that you have, the more likely you are to experience adverse health outcomes. And so they give you a score, and based on your number of adverse events, predicts kind of the likelihood that you're going to have poor health outcomes. So you have these adverse childhood experiences that then shape your social, emotional, and cognitive behaviors that then affect your risk, your health risk behaviors, then your disease, and that can lead to premature death. So just because what's happening in our kids may not seem to matter a whole lot, it matters a whole lot what's going on in childhood. And what they're showing and seeing is that kids that have increased levels of these adverse childhood experiences, particularly childhood abuse, neglect, and exposure to other traumatic stressors, those things like single-parent families, which African American kids, 38% of African American kids live in a single parent family. Over 38% of African American kids don't have access to health care. Those are adverse childhood experiences that lead to premature death over time. Stigma becomes a huge issue. Again, in talking to my students, and I'm saying, well, what do I mean by mental health, and what are we talking about? And they're like, when you lay on the couch and you just spill your guts, nobody wants to. I'm like, well, do you know that's what happens? They're like, no, but I've seen it on TV. And so we have a lot of media portrayals about mental illness. And so we know through research, of course, that in the absence of experience with mental illness, the media can shape what we believe. Right, and so we have shows like Celebrity Rehab, which I have never seen that, by the way. But you have shows like Celebrity Rehab and Mad Men, One Flew Over the Cuckoo's Nest, and Sybil, all of these things that present these extremities that then shadow and portray an image that may or may not be reality for so many people. But then you compare that to the stigma that happens with mental illness for African Americans, and you have these kind of discordant realities where you have a group of people that's known for resilience and overcoming obstacles, and you compare that with someone that can't get it together or is struggling with paying the bills. How do you match that up and still say, I need help? Sign me up for that. It becomes a struggle. When you have a culture that's steeped in faith and spirituality that says God will take care of you, just believe, and you still have the issue, what do? Right? Amy? No. When you have a culture for men that says men don't experience emotions, and if you do experience them, you really don't show them, right? And so then to say I need help becomes a big problem and issue. Or when you say I'm uncontrolled and I need help, these become huge issues which then relate to us not seeking care. So we know that African Americans tend not to discuss mental health issues, that mental health is not recognized by a lot of people, but then that speaks to a lack of treatment, which then leads to physical problems, which we see manifested in disparities, right? So I'm depressed, but I don't know that I'm depressed, so I'm going to eat and not eat an apple. I'm going for Ben and Jerry's. And then I'm going to eat some more because the problems haven't gone away. And then my doctor says, you have high blood pressure. And your family history of high blood pressure means you're more likely to have a heart attack. So what do I do then? How do I make all of this stuff make sense? So all of these things, fear, embarrassment, language, trust, mental health literacy, all of those lead us to seek treatment in some untraditional ways, untraditional to others, right? So we go to pastors and ministers, the clergy. We go to native healers. We go to emergency rooms and our primary care doctors, things that and systems that might be untraditional to a lot of people, but these are the systems that we need to equip with the knowledge and the power to effectively help us as we're dealing with all of these issues. So then when we don't seek treatment, we see increase in acute episodes. We see chronic conditions that are prevalent in terms of disparities for minorities. So you see higher rates of cardiovascular disease. You see higher infant mortality rates. You see higher instances of cancer. You see an increased risk of death. You see uneven utilization of services and a lack of quality of care because we're just not recognizing the issue overall. So then we have to balance this out. We talk a lot about public health approaches, But when we're focused on the problem as an individual problem, the balance then becomes individual. It's your responsibility to take care of. And we have to move from just this individual approach to a true public health approach where we're saying it takes all of us coming together addressing the problem in order for us to see the differences that we need to see. So misunderstanding, prejudice, discrimination, judgment, social exclusion, those individual level issues, what we see in our communities are system level responses. So we see things like more jails, more people being incarcerated. We see tightened background checks, right? We see this conversation about increased security and police issues. For African Americans, about 45% of the jail population is African Americans. And we saw earlier that 80% of the people in jail have mental illness issues. And so if we have the responses to put you in jail, but we're not going to do anything to help you, we're just going to perpetuate the problem. And so what's going on? What's happening? What can we do to make a difference? And so we have to, someone said it earlier, we have to stop separating these issues of mental health and physical health. We have to address them comprehensively because what happens in one area really does impact the other. So we have to start thinking of this comprehensively. We have to look at parity, which means insurance provision for mental health services in equal proportion to what's happening on the physical health care side. Primary care providers need to be equipped on mental illness and how to recognize this within our communities. I think in the last talk we touched on the fact that minority groups tend to utilize primary care services, but if my primary care physician wants me to come in and say I'm depressed and that doesn't happen, then my depression will never be treated. So recognizing what that looks like for different communities becomes important. We have to have this movement toward destigmatizing destigmatizing mental illness within minority communities, particularly African American communities. We last week we had our Minority Health Forum focused on mental health at Langston, and one of the speakers she's a professor at our university, and she disclosed that she was bipolar, and you would have thought that this was a huge announcement. No one could believe that she got up and said, I have bipolar, and went on to really disclose her condition. And afterwards, as I listened to other people talk, they were like, can you believe that? And she teaches here. Oh my gosh, you can do so much. But this idea that we can destigmatize some of these conditions will move us greatly in terms of reducing our disparities in this regard. And then we have to continue cultural competence training for mental health practitioners. We have to continue this dialogue with others, because it's great that we know, but we have to take the message outside. We have to take it to those that are treating us, those within our community, linking people to services in a way that makes a true difference. We need to foster greater interest in mental health amongst our young people. Dr. Lewis talked about there's only 6% of African Americans in the medical community, and that becomes even less when you talk about behavioral and mental health service providers. The latest statistics was 4.1% of mental health providers were of any minority background. So who knows what that minority composition is. And if we know, we like to go to people who look like us, talk like us, have experiences like us, but if that's only 4% of the population, that's not happening. Dr. Lewis will have a long, long, long job. So we have to encourage this interest in this field for our younger people. And we have to really focus on social determinants of health, not just because it's the buzzword of the day, but because these issues really do impact our health outcomes. So we are taught a lot about CPR and first aid, and we know the signs and symptoms for choking, and we know about nutrition and physical activity and where to go in an emergency, but we don't know about signs of suicide. We don't know about signs of depression. We aren't talking about how our behavioral health and our physical health are linked up. We're not talking about what happens in our childhood, how it affects our future. And we have to change that in order for us to see a true difference. And we have to change it now, right? So we need to engage everyone. We need to be looking at the data so we know where to focus our efforts. We have to focus on prevention and be committed to making a difference.